When a patient enters acute respiratory distress, the physical signs are immediate. You see rapid, shallow breaths. You see the neck and shoulder muscles straining to pull air into the lungs. You see a visible struggle to survive. But in nursing school, you don't evaluate a crashing patient at the bedside. You evaluate them through a multiple-choice question. The physical urgency is replaced by 4 text options. Memorizing textbook definitions of lung diseases will help you pass anatomy. To pass clinical priority exams, you have to translate physiological facts into immediate clinical actions. Every decision follows the ABC framework: airway, breathing, circulation. If the airway is closed, nothing else matters. Within that framework, gas exchange, the movement of oxygen in and carbon dioxide out, dictates the timeline of your response. When gas exchange fails, organs shut down. We are going to examine the 2 primary respiratory conditions tested on nursing exams: asthma and chronic obstructive pulmonary disease, or COPD. We will break down the underlying pathology of each, map the clinical signs of early versus late deterioration, and establish strict rules for pharmacological intervention. Stating that a patient has an airway obstruction is an observation. Administering the correct medication in the correct sequence to open that airway is clinical judgment. Asthma is an acute reactive airway disease. It is triggered by environmental allergens, stress, or cold air, resulting in sudden airflow obstruction. Crucially, this obstruction is reversible. This diagram compares a normal bronchiole to an asthmatic one. During an asthma attack, the smooth muscle surrounding the airway rapidly constricts. Simultaneously, the inner mucosal lining swells and produces excessive mucus, severely narrowing the passage for air. Because this narrowing is driven by sudden muscle spasm and inflammation, the structural integrity of the lung remains intact. With rapid administration of bronchodilators, those muscles relax and the airway can be forced open again. COPD operates on a completely different timeline. It is a chronic, progressive disease characterized by permanent damage to the respiratory tract. COPD encompasses 2 distinct pathologies that typically occur together. Chronic bronchitis involves constant inflammation and heavy mucus production in the bronchi. Emphysema is the physical destruction of the alveoli, the tiny, fragile sacs where gas exchange actually occurs in the lungs. This anatomical illustration shows the structural effect of severe COPD. As the alveoli are destroyed, the lungs lose their elasticity. They become hyperinflated, leading to a permanent structural shift known as a barrel chest. This loss of elasticity traps air inside the lungs. The patient struggles to exhale effectively. Over time, this air trapping leads to chronic carbon dioxide retention, permanently shifting the patient's baseline acid-base balance into respiratory acidosis. Asthma is a temporary plumbing issue. COPD is permanent structural damage. Recognizing whether you are treating a reversible spasm or a chronic state of compensation dictates every clinical protocol that follows. This is the deterioration spectrum. To intervene effectively, you must identify exactly where your patient sits on the timeline between early compensation and late respiratory failure. When airflow is initially compromised, the body attempts to compensate. The patient breathes faster to intake more oxygen. They develop dyspnea on exertion. Often, the first neurological sign of dropping oxygen levels is mild restlessness or anxiety. You will also hear wheezing. A high-pitched wheeze indicates that air is squeezing through a tightened passage. It is an alarming sound, but it confirms that air is still moving. If the obstruction worsens, compensation fails. Hypoxia deepens, leading to cyanosis. Carbon dioxide builds up, causing somnolence and confusion. The accessory muscles finally fatigue from the immense effort of breathing. At this stage, the most critical indicator of total ventilatory failure is the development of a silent chest. If an asthmatic patient has been loudly wheezing and suddenly their breath sounds become diminished or absent, they are not getting better. The airway has clamped down completely. An abrupt transition from a loud chest to a quiet chest without the administration of bronchodilators indicates imminent respiratory collapse. Your first non-pharmacological action for any dyspneic patient is positioning. Placing the patient in a high Fowler's or tripod position uses gravity to pull the abdominal organs downward, allowing the diaphragm to fully expand the lungs. In a severe asthma attack, the patient is suffocating due to an acute blockage. You must administer high-flow oxygen immediately to correct the profound hypoxemia. There is no restriction on oxygen delivery here. Patients with COPD require a different approach. Because they chronically retain carbon dioxide, their primary physiological drive to breathe relies on low oxygen levels. Flooding a COPD patient with high-flow oxygen can suppress this hypoxic drive, causing them to stop breathing. Their target oxygen saturation is maintained strictly between 88 and 92. This brings us to the absolute sequencing rule for respiratory pharmacology. When a patient is in distress, rescue medications always precede maintenance medications. Never administer a corticosteroid first during an acute attack. If you try to deliver an inhaled steroid into a clamped-down airway, it cannot bypass the constriction and will not reach the lungs. You must first administer a short-acting beta agonist, like albuterol. Albuterol acts directly on the smooth muscle receptors, rapidly relaxing the spasm and opening the airway passage. Once the SABA has established a patent airway, you administer the corticosteroid. The anti-inflammatory medication can now travel deep into the respiratory tract to reduce underlying mucosal swelling. Immediate mechanical opening of the airway must always precede long-term inflammatory control. That sequence is what saves the patient's life. Priority questions on nursing exams require a specific elimination strategy. You are usually presented with 4 actions that are technically correct, but only one is the immediate priority. Elimination Rule 1. If the patient is physiologically unstable, discard any non-urgent actions. You do not teach pursed lip breathing or gather dietary history while a patient is gasping for air. Eliminate the teaching and assessment distractors. Elimination Rule 2. Do not pass the buck. Calling the provider is rarely the correct first action if there is an independent nursing intervention, like applying oxygen or positioning the patient, that can stabilize the airway right now. Elimination Rule 3. Prioritize neurological status over numerical data. A subtle decline in level of consciousness, like new-onset lethargy, takes precedence over isolated vital sign readings. Cognitive failure is the most reliable indicator of worsening gas exchange. Standard nursing exams test prioritization. The correct answer is always the action that most directly and immediately prevents the patient from dying. Consider this scenario. You have an asthmatic patient who received an albuterol treatment 10 minutes ago. Now they exhibit no audible wheezes and appear drowsy. Applying the deterioration spectrum, lethargy combined with a silent chest indicates that the rescue inhaler has failed. This is status asthmaticus, and the patient is entering respiratory failure. The immediate implementation escalates past basic interventions. You must prepare for emergency intubation, administer continuous high-flow oxygen, and deliver intravenous corticosteroids. Now look at a second scenario. A patient with a 10-year history of COPD reports increased dyspnea and is coughing up thick green sputum. These cues form the classic triad of a COPD exacerbation. The patient has an increase in baseline shortness of breath, an increase in sputum volume, and a change in sputum color, which indicates an active underlying infection. The required implementation is to support gas exchange without suppressing the respiratory drive. You position the patient upright, apply targeted low-flow oxygen to maintain an 88 to 92% saturation, and prepare to administer bronchodilators. Clinical judgment is the vital bridge between recognizing these subtle physiological red flags and executing decisive, life-saving interventions.